Yesterday we have the fortune to listen the nice lecture about the biceps tendon from Mark and Javier. It is really amazing. So I think that would be nice to start with the exploration, just a quick demonstration to refresh what they said about the biceps tendon. And of course, Javier, whenever you want to start. Okay. First, how to explore the biceps. I suggest it's very important to keep the end hyperpronated, just to expose as much as possible the hyperstopinated, sorry, just to expose as much as possible the radial tuberosity, that is the real point where we have to see the attachment of the biceps. So like this, then at least 40 degree of flexion, and just to put in a little tension the tendon, and then we start very proximally. Okay, starting proximally, and just to see the complete anatomy. Okay, we start here. So we have this is the myotendinous tendon junction, the load at the biceps. This is the insertion of the pectoralis major, and this is the short head of the biceps. Okay, so now we see that the long head is lateral, the short head is medial. You can separate in between the two heads. You just if you keep moving distally, okay, there is the brachialis muscle that start to appear, and we see that the eccentric intramuscular aponeurosis start to appear. As Mark said, that there is a lateral component and a most medial component. Okay, the lateral component is what we give the final biceps tendon, the main component of the biceps tendon, and instead the most medial one is what go to the lacertus fibrosus. And notice that even very close to the myotendinous junction, still we have the separation of the two heads. We have the lateral one that is becoming little here, and the medial one that is becoming further little here. Then they joint. But as has been demonstrated, once we are more distal, you are with a play of tilting the probe, you still are able to recognize the two head here, 1 and 2, lateral and medial. Okay, lateral long head and medial short head. Once you move distally, you see till one is hyperechogenic, the other one is hyper, and with a play of tilting you can distinguish them very well. Once you go distally, you see the lateral one tend to go inferior and deep. Instead, the medial one, that is the short head, tends to stay up. And this is very clear here. Okay, 1 and 2, two heads. Of course, when you started to go distally, it's very important to always adjust the of course the machine, the focus of the machine, but also the tilting the probe to make the tendon always hyperechoic to avoid anisotropy, to see exactly the insertion and if there is any pathology or not. The concept that is the superficial one that is from the superficial one that is from the short head goes more anterior here, and the posterior one that is from the long head stay a bit more posterior and in depth. Okay, so this is the first concept to explore the biceps tendon. The only before seeing the biceps tendon long axis, I just to remind you that close to the biceps tendon we have a small nerve that is, that iliac nerve, and there is this small nerve that is lateral antebrachial cutaneous nerve that is located in between the biceps and the brachialis here. Okay, this is the terminal branch of the musculocutaneous. It's a kind of the saphenous nerve for the femoral nerve, the sensitive terminal branch. It exits just on the lateral side of the biceps between the cephalic vein and the biceps. and it could be relevant because I think that also your experience when you have a complete rupture, retraction of the biceps, could have some kind of neuropathy, and the nerve looks. These are the fascicle of the nerve. Looks enlarged and it could be could contribute to the symptomatology, sensitive symptomatology of the biceps rupture in this point.
And also for surgery.
And then also for Xavier saying that is also important for surgery. Then it divides, and remember that the both distal branches of the lateral antebrachial go to innervate until the wrist. Okay, so it's a very long nerve, but of course at the point where it's much more exposed to the pathology is is in between when you exit underneath the biceps tendon between the cephalic vein and the biceps tendon, just in this point. These are the fascicle. But now we go with the exploration. We continue with the exploration of the biceps, okay? Because in this when we need the confirmation of a lesion, we need also the images in two axes of any tendon and also for the biceps. But if we put the probe just over the biceps with this technique, sometimes we are not able to see that perfectly. Moreover, at the level of the insertion, well, in this case is probably also for our model is quite easy to understand, but sometimes it could be very hard to see exactly the insertion of the biceps on the radial tuberosity. That is the most important finding when you explore the biceps. You cannot be only happy with the tendon junction. You have to see the insertion the radial tuberosity, okay? And you also see that moving from lateral to medial, you can recognize the two components. One exactly, one there more posterior deep, and the other one more anterior superficial, okay? So, which is the technique to see very well the biceps tendon to be sure about the insertion biceps tendon? I suggest to start immediately. Okay. 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 This is the joint line. I start to go medially. I find first this tendon that is a bit easier to find. Okay. You see the orientation by probe. This is the brachialis muscle, and this is the intermuscular tendon, the brachialis muscle that go to insert here of the ulnar tuberosity. Okay. Um, of course, then I move laterally like this, and I perfectly in the long axis of the biceps. Just the probe from medial to lateral. Okay, this is a nice view of the tendon, a complete view of the tendon. Okay, and why using this landmark, the brachialis muscle, the tendon of the brachialis muscle? Because they are perfectly parallel. Okay, if we use other landmark, I can. This is the insertion, the brachialis. If we use the artery, you see that the artery sometimes is not so exactly parallel to the tendon. Is an oblique. So to me, this is a good technique to see very well the insertion of the biceps tendon. Okay. The last thing that I suggest biceps is just yes. Okay. Thank you. Okay. So place the arm like this. You make a kind of cobra with the arm in this position. And you place the probe exactly posterior. Okay. And so what we see? We start. If we move place the probe here, you see this, this is the ulnar side here, and this is the radius, okay? This is the radio-ulnar space. If I move proximally, in this point, I see that there are two structure with a round shape, okay? This is the supinator muscle, and what we see here is the insertion of the bicep tendon, okay? And of course, is
Igual dile que nos dé un poquito más de gel, por si acaso.
yeah, you can use this maneuver to check if there is any impingement or if there is distension of the bicipital radial bursa in this point, okay? This is a good maneuver to explore just the insertion. And could you please freeze? Thank you very much. And yeah, exactly. As Xavier is saying, is a good place also to inject, because you see, this is the tendon, but what we see here is the bicipital radial bursa, okay? And when you have impingement or degenerative changes, quite often you have the distension of this bursa, okay? And remember that could be also involved in case of the rheumatologic disease. You can have some synovium inside the bursa, because in any bursa there is a synovial tissue, okay? So keep in mind this free maneuver for the biceps. Is there something that you want to add?
No,
Xavier?
¿Alguna duda, alguna pregunta sobre el bíceps en la exploración? No.
Okay. Okay. So for just a few words about the elbow, about exploration the elbow, and usually when we start to explore the elbow, the first thing we check is the joint. Okay, the recesses, the joint line, and then the ligaments around the elbow, and then of course the tendon. Okay, so we start with the humerus just in the middle of the screen, and if we go distal, we see that there is a shape, this shape of the humerus. Okay, there are two fossae. One is ulnar and one is radial. Okay, this fossa is the recesses of the first recesses of the wrist joint, and the ulnar quad is coronary fossa that is a bit more deep, and the radial one that is the radial fossa. This is a bit more shallow. And this is the first point where you have to check for any fluid or synovium. Okay, both in, and again, in short axis like this, but also in long axis, so you have a really an idea of the recesses. You see, this is the cartilage that ends here in the supracondylar area inside the radial fossa, and this is the ulnar fossa that is definitely more depth. Okay, now we have see the recesses, and then we progress distally, and we check the cartilage. Okay, the cartilage of the humerus with the radial capitellum or on the lateral side, and the ulnar trochlea, this level. Okay, of course, pay attention to adjust the probe just to make to be sure that there are no irregularity in the cartilage, and explore from one side to the other side. And again, also in this case, it's very useful to place the probe longitudinally to see the cartilage of the radial capitellum, but also the cartilage over the radial head. Pay attention that according to the position of the radius, we could find any cartilage. Okay, if the arm is in pronation, you don't see any cartilage, and any cartilage could be misleading. Instead, if you place the arm in supination, the cartilage is very clear. Regarding the coronoid process, there is always the cartilage here, but is a bit more less evident. And what we see instead is the cartilage over the ulnar trochlea, yes, on the humerus, yeah, and of course overlying the brachialis muscle and the tendon. You know that brachialis muscle tendon is something is quite a common injury, and moreover in a climber, because I have a kind of grip when that and engage much more the brachialis muscle than the biceps. So definitely in case of pain in a clammy is definitely something that you want to check that. So the last recess of the elbow that is important to explore is the olecranon recess. Okay, olecranon fossa. Thank you. Just put the arm flexed like this, place the probe here, and you have the recess here very well aligned. This is the recess, this is the joint space. Okay, remember that there is a little fluid there, but pay attention that sometimes with the fat here could be also very homogeneous, so could be misdiagnosed as a synovium of fluid. The recess, this is exactly the shape of the recess, okay? And you can even grade the case in case of arthritis or in case of rheumatologic disease. The grade of joint involvement according to the shape of the recess. This case is paraphysiological, but when the bump reach the level is moderate, and when overcome the level between the level between the condylar process to the end of the olecranon fossa is severe involvement. Okay, and once we are here, just exploration is important to explore also the tricep tendon. Maybe if the patient is able to do that, is a nice disposition to explore, because the tricep in this way is a really intention. But of course, not all the patients are able. And this is the triceps. And remember that the insertion go exactly on the olecranon and a bit more distal position. Okay, here, and the insertion on the triceps is quite wide. And you remember to explore from one side here to to the other side. And also remember that sometimes the medial edge of the triceps got to insert a bit further. Or you see, this is the medial head, is the one that go not to insert exactly on the olecranon but go a bit further. And this is also why quite often for this type of insertion, in case of hypertrophy of the medial head of the triceps, you can have a dynamic compression of the ulnar nerve that is just there, because the insertion is a bit longer respect of the other insertion of the triceps. As as in the triceps, we can recognize different aponeurosis. The most superficial one is from the long head there, and the intermediate one is from the lateral, and the most depth there coming from there is from the medial. Okay, so you can also differentiate the different aponeurosis. Now, we do you want other something?
No.
Okay, it's okay.
Only feel tired.
No, it's okay. So we completed the exploration on the elbow with the medial side and the lateral side. So for the medial side, there are two main structures that you have to check. First of all, the common origin, the flexor. And for the common origin, the flexor, again, the 40 degrees position of the arm is a really good start. And pay attention to place the probe a bit in oblique manner respect of the long the long axis of the forearm. Okay, just to have a complete exploration of a really good exploration of the common origin that is at this level, because instead for the other important structure that we have to explore, that is the anterior band of medial collateral ligament, that is that one. Okay, you have to place rotate the probe a bit more posterior, almost in the long axis of the forearm, maybe with the one edge of the probe a bit more posterior. You see it quite well, going to insert from here from ear to ear. You see the insertion here, and of course underneath the medial collateral ligament you have the recess of the joint. Okay, to not confound with a split of the medial collateral ligament. Okay, you go to insert on the process of the coronary process of the ulna, and the anatomists describe a kind of tubercle that is called the sublimis tubercle at this level. Okay, but just for your curiosity, the important thing that you check the insertion, you check the origin, you check the recess, just the medial recess just underneath. This is the most important part. This is the anterior band that is the most important. For the posterior band is less significant, but if you want to explore it, is just sufficient if you go in the cubital tunnel, because it is exactly the okay, here, perfect. Is exactly the floor of the cubital tunnel. Okay, this is this structure. Thank you. This structure that is a hammock shaped structure. This is the posterior band of the medial collateral ligament. Okay, but from the biomechanical point of view, it's not so relevant. Atlas is describing anatomy that is not so relevant. The most important is the anterior one. For the lateral epicondyle, arm in 40 degree in neutral position, sorry, arm in 90 degree of flexion, elbow with 90 degree of flexion, with some in neutral position, and we discussed a lot with Xavier about that, because it's another interesting topic. So basically what we need to explore all the structure that takes origin that we go to insert on the lateral epicondyle. And this structure are the common origin of the extensor tendon and the lateral collateral ligament. Okay, at least the proper lateral collateral ligament, because the other, we see later the other component. And in long axis, you can perceive that there is a kind of differentiation. Okay, moreover, in the middle part of the epicondyle process, you see that there is a most superficial component, and for the anisotropy, you see a most deep component. Okay, the deep component is likely related to the proper lateral collateral ligament. The most superficial one is related to the tendon of the extensor. Okay, but if you move anteriorly, that is no more true. That is no more true, because indeed more anteriorly, what we see there is only tendon, and in particular the extensor carpi radialis brevis and the extensor digitorum. And the same if we move very posterior, where we have the tendon extensor carpi ulnaris inserting here, and we can have a confirmation of that like this. Okay, we start at the very beginning of the epicondyle, there where there is nothing on the epicondyle. If we go distally, we see that there are many structure, and just before reaching the annular ligament over the radius, we have some myotendinous junction here that is related to the extensor digitorum and the extensor carpi radialis brevis in this point. And just in the middle, this is the real area of the lateral collateral ligament, just in the middle here. And the most posterior part, instead, that I got to insert here is from the ulnar extensor tendon, extensor carpi ulnaris, and the extensor digiti minimi. Okay, so it's a complex insertion. Just to point out that could be is when you to explore that. Yes, or even better with the okay stick. When you explore that region, there are many structures. There are just to call a lesion. Pay attention to which structure you are looking at, because you are able to differentiate. So basically, if again this is the tendon, we are anterior now. Okay, in the most anterior part, this is the tendon extensor carpi radialis. The most superficial is the tendon of the extensor digitorum communis, here that go to form the most superficial component. If we move in the center more posterior, we see that in this central part there is an hypogenic area, and this is related to the lateral collateral ligament. Okay, and instead in the most posterior part you have the two tendon, the extensor digiti minimi and the extensor carpi ulnaris just there. Okay, this is a good reference in short axis to evaluate the lateral epicondyle. The last two ligaments to evaluate around the elbow are the annular ligament and the so-called lateral ulnar collateral ligament. Okay, so basically what you have to do is go on the radial edge, just a level of the cartilage, and then move posteriorly, and just with the arm okay, here with the arm in supination, you can see in pronation, sorry, and you can see that there is the cartilage, the capsule with reinforced by the annular ligament, go to insert here in on the ulnar supinator crest in this point. Okay, for the lateral ulnar collateral ligament, maybe I need a wider probe to demonstrate, because it's a very long ligament. Okay, the lateral ulnar collateral ligament is believed by many anatomical studies to be the main stabilizer of the radial head against the posterior dislocation. Okay, against the posterior dislocation, and then of course all the ligamentous complex is very important, but is worthy to be checked. So again, we start with the I suggested to start with the annular ligament that we see the insertion here, and then move a bit proximal and rotate the probe in this way, and what you to see is the structure that go from the condyle over there, from the condyle, go over the radial head that is in this point, cover the radial head, and go to insert again on the okay, go to insert then on the supinator crest. This is the level of the lateral ulnar collateral ligament. Of course, the best way to demonstrate that is but yeah, yeah, exactly. A bit more over the radial head is a unique complex that blend with the annular ligament over it, and yes, and they go to insert the supinator crest. Is a kind of hammock that keep the radial head in this place during pronation and supination. Okay, during pronation supination, this ligament is the structure that is believed to be very important for the stabilization of the radial head. And of course, when you have also fracture, you can have a compromission of this ligament, and the result of the stability of the elbow could be compromised. Okay, here you see here this point. Yeah, yeah, yeah.
Losing the head here.
Okay.
More anterior.
More anterior. When you see you have to the head on the radius within. Okay. So this is for the elbow, the most important thing for the elbow, I think, that are, yeah. So for the forearm is
If you are tired, you have to only do that.
hmm?
If you are tired,
No,
okay
it's
for you.
okay. Whenever you want to show something.
No.
It's so for in the forearm, it's just important to keep to have an idea of the destruction running into the forearm, starting from lateral to medial. Okay, so basically the muscle layer in the forearm go from a superficial structure to the deep structure, and so the most superficial one The most superficial, the first layer of muscle is made up with the flexor carpi radialis here and the palmaris longus. So they both they takes origin from the common flexor origin here, and then they move distally, and what we have is the first layer just over it, and this is the position. Okay, so here the first layer we have the flexor carpi radialis and the palmaris longus that are the most superficial. This is the aponeurosis within the flexor carpi radialis, and this is very thin is the aponeurosis of the palmaris longus. This is the first layer. Just underneath the first layer, the middle layer is with the flexor digitorum superficialis. Okay. The flexor digitorum superficialis that is interesting to notice the shape of this the configuration of the tendon just more distal, where the second the muscle or the second and the third fingers sometimes are inverted. We just just to elicit the movement of the superficialis is we have to flex the whole finger, okay, like this. Okay, just the finger like this for the superficialis. Instead, if we flex also the last phalanx, we have both superficialis and the profundus. Maximum flexion like this, the profundus, this is underneath. And the configuration of the second third finger and the superficialis is just inverted. Okay, well, for the second finger is more lateral, the third finger is a bit more medial. You see, the third finger contract here, and the second finger contract here. Just to pay attention that sometimes in this flexor superficialis you don't have exactly the same anatomy that you have in the finger. Instead, the flexor profundus, the tendon are much more aligned, and is quite easy to recognize each tendon. Okay, is useful from the when you check for tendon integrity to know this specific anatomical configuration. So we've seen the flexor digitorum superficialis, we see the palmaris longus flexor radialis. Of course, in the middle layer, on the superficial middle layer, we have also the flexor carpi ulnaris. Don't forget the flexor carpi ulnaris, and that is quite interesting. Moreover, for the fact that is a good landmark for the ulnar nerve. Okay, just that it lies just underneath the flexor carpi ulnaris and the part of the flexor digitorum superficialis. Moreover, more distally, it's quite clear that underneath the flexor carpi ulnaris there is the ulnar nerve with the ulnar artery. Okay. So the last layer instead is related to the third layer indeed is related to the flexor digitorum profundus and the flexor pollicis longus. Okay, and if we flex the thumb, you can distinguish very well the flexor pollicis from the flexor digitorum profundus, that is all the other things. Okay, in between the two compartments of the flexor superficialis profundus you have the medial nerve just here. Okay, and one maybe most of you know that is quite funny to check for an accessory muscle that most of people have, that is the so-called Ganser muscle. Okay, it is described an accessory belly muscle of the flexor pollicis longus, but somebody says so that is an accessory muscle of the flexor digitorum profundus. Okay, and how to find that? When first of all we check for the flexor pollicis longus, flexing like this, and we move proximally. Okay, theoretically the flexor pollicis longus go to insert only on the radius and the interosseous membrane. But if you keep it to move the flexor pollicis, sometimes you notice that there is something more on the more medial that doesn't go to the radius but go much more proximal, and this is the Ganter muscle. Is of course is a quite common variation, and why is being explored this particular fascicle? Because it's believed to in some way to predispose, but is only a speculation because then is not very well demonstrated, to predispose to impingement against the anterior interosseous nerve that runs with the anterior interosseous artery just close to it. Okay, and quite easy to differentiate, keep that moving, and because what happened basically, you see this is the median nerve. Okay, the median nerve moving underneath the pronator muscle. Okay, we're in the place where release in the place that in the lowest point of the median nerve, just here, there is a septum where some fascicles are released. Okay, together with the interosseous artery in this point, and then you can continue to follow that, some branches here that reach the interosseous membrane at the end. Okay, so here there are different muscular branches, yes, but if you use as a landmark to understand exactly where the anterior interosseous nerve is, you can keep the flexor, the thumb moving, and the anterior interosseous nerve is always in between the flexor pollicis and flexor digitorum profundus. So if you continue to flex and extend the thumb, you see perfectly, that is, you see perfectly the area where the anterior interosseous nerve is, and of course you see if there is also Ganser muscle. But this is more an academic interest than a real important point. What could be nice to explore is the relation with the of the median nerve with the relation median nerve with the pronator teres. Okay, because there is a variant shape of the relation between the median nerve and pronator teres. So we have the pronator teres here, and we have the median nerve. Okay, so very proximally the median nerve is over the median nerve there is a lacertus fibrosus there. Then we move median nerve is underneath. Okay, and if we move we see that the median nerve is between the pronator teres and the brachialis muscle. The brachialis muscle will go to disappear, and the median nerve here in this case just starts to go up. Okay, this is the point. You see that we have two muscular tissue over the median nerve and down the median nerve. Okay, here, just here. And before going in between the flexor digitorum and flexor digitorum superficialis profundus, the median nerve go in between these two layer muscle. This is part of the belly of the pronator teres. Okay, so basically you could have the median nerve that just go underneath the pronator teres on the median nerve that appears the pronator teres. Okay, and sometimes according to the specific variation on the median nerve in relate to the pronator teres, you could have some compression, possible compression at this point. Of course, for the median nerve, the critical point for compression at the level of the elbow or underneath the lacertus fibrosus there, and then at the level of the tunnel within within the pronator, just in this point, and also when I go inside the sublimis ridge. Okay, the sublimis ridge is the flexor, also called the flexor digitorum superficialis arcade, and is is it is in this point, okay? You see where when this is the median nerve long axis, like this. Okay, median nerve long axis. This is still underneath the pronatus teres here. The small amount of pronatus teres. Thank you. The small amount of pronatus teres here. So in this case, we have this configuration. Sometimes the second belly pronatus teres is much bigger, or sometimes the median nerve just go underneath. And then this part is the level of the sublimis bridge in between the different heads, between the radial ulnar head, between the different head of the flexor digitorum profundus. Okay, between the radial and between the ulnar radial origin of the flexor digitorum profundus. So these are the main things for the forearm. Then we move distally. Look at the relation between the ulnar artery that goes from the median nerve. Here is close to the median nerve in this point, and then it goes to the ulnar nerve, and just could be a good reference for both of the nerve. Proximally is close to the median nerve, and then distally go with the ulnar nerve. Regarding ulnar nerve, just be aware that before reaching the wrist, you release a secondary branch that is indeed quite that could be relevant, because it's possible to see pathology of that. And just it decrease a bit. Okay. And you see here. So here we are 4 or 5 centimeters from the crease of the wrist, and you see this fascicle moving posteriorly just on this point, and this is you see it very well. This is the dorsal cutaneous branch of the ulnar nerve that go to innervate then the fourth and fifth finger on the dorsal aspect. Okay, and sometimes you can have a neuroma or pathology, any kind of pathology of this nerve, and it's important just to be aware of that, to look for that in case of a selective anesthesia, selective loss of sensitivity on the ulnar aspect of the dorsal part of the end. Okay, just move the wrist. We see later about the carpal tunnel, what are the landmark for the carpal tunnel that are also useful to have an idea of the anatomy of the wrist. Okay, so this is the median nerve in between the flexor carpi radialis and flexor digitorum. When the median nerve approach the carpal tunnel, we need to find the appropriate landmark just to be sure to respect the plane of the transverse carpal ligament. Okay, and our landmark are the scaphoid tubercle with the flexor carpi radialis over it, and the pisiform with the flexor carpi ulnaris over it. Notice that close to that we have the Guyon canal, where we have the ulnar artery and the ulnar nerve. Okay, is the Guyon is created by the flexor retinaculum just underneath, a split of the palmar ligament that just go over it. It is a triangular shaped space that you see it very well. So when you are here, you are sure to be in the correct plane for exploration of the tunnel, which is the content of the tunnel. Just adjust the gain, adjust the depth, because it's very important to explore also the floor of the carpal tunnel. So the content we have 9 tendon level of the carpal tunnel, are the 8 flexor and the 8 are the 8 flexor for superficial for depth, and the flexor pollicis longus on this side. If you move, you can see that. Okay. While exploring the carpal tunnel, it's important to notice, it's important to perform it dynamically, because moreover to see if there is any tenosynovial tenosynovial thickening of the tendon sheet or the burst, because somebody say that what we have in the carpal tunnel are not real the tendon, a common tendon sheet of the all the flexor, but are two bursts, one radial over around the flexor pollicis longo, and the other one with the E shape like this in between the two rows of flexor carpi flexor digitorum. But anyway, what you just moving like that, you can see if among the different flexor tendon you have some hypoechoic structure, you have some effusion, and that is could be a predisposing cause of the carpal tunnel. Okay. When you explore this carpal tunnel, also pay attention to the floor of the carpal tunnel, because underneath we have some. Yeah, okay, you're right. Because sometimes the pathology related to carpal tunnel doesn't come only from the tenosynovium, but come from the structure underneath. And remember that there are recesses, and moreover there is a thick layer of ligament, the palmar ligament. Okay, you see from ear to ear, it looks like a unique structural ligament. And also when you do a macroscopic anatomic, this just look all the same ligament. Indeed, is the union of the different component of the volar extrinsic carpal ligament, that is from the radius to the lunate, radiolunate, radiocapitate, this stabilizing complex. But it's very difficult to see a selective pathology of all the ligament. You just have to check if there is any expansion on the recesses at this level, and if there is any abnormal thickening of the ligament. Okay. Regarding the detail of the carpal tunnel exploration, we will see the lecture moreover regarding the small nerve. Just focus the attention on a few details. For instance, the flexor carpi radialis. Okay, you know that the flexor carpi radialis could be quite frequently involved in degenerative changes. Okay, and what to know that the exploration of the flexor carpi radialis could not be limited or the ulnar to the scaphoid tubercle, but it goes further distally. Okay, and to explore the most distal component of it, you have to tilt a bit the probe to see its insertion over the base of the second metacarpal bone. Okay, and you see this is the trapezium, the trapezium tubercle. You have just to look for the medial aspect of the trapezial tubercle. So you have to. I'm not exactly in the long axis like this in a sagittal plane, but you have to tilt the probe in this way. Okay, to tilt the probe both medially, and so you are able to see the flexor carpi radialis. Once you see the flexor carpi radialis and you move medially, you see another structure. Okay, you see this is the trapezium. Okay, this is there is a structure here, and this is another bone. Okay, this is the cross section, the anterior oblique ligament. Okay, that is the one of the stabilizer of the trapezium metacarpal bone. Now I am in the long axis. It is at this level. It is very medial. Okay, and is believed according to some anatomists and also Donald Resnick, that is a radiologist working moreover on magnetic resonance, to be the first to be altered in with arthrosis, in arthritis of the trapezium metacarpal joint. And once you have a degeneration of this ligament, then you have a change in mobility of the trapezium metacarpal joint, and this is the first trigger to the process of the arthrosis, of the arthritis. So once I'm here, like this, I just translate the probe laterally, and I see the ligament. This is the cross section of the ligament, and this is the first metacarpal, and see another part of the ligament. So here to here, okay, and if I put in long axis is the very short ligament here. It's very of course a thickening of the capsule, but is could be important. When you explore the flexor carpi radialis, consider that could be alterated at this level, where from some bone is pure osteophytes at level of the so-called triscaphe joint, that is in between the scaphoid, trapezium, and trapezoid. Okay, and when you have a spur, we are a prominent spur at this level, you can have injury of the flexor carpi radialis because they go very close to all this bone. Okay. Regarding always the trapezium metacarpal joint, another important ligament stabilizer is the dorsoradial. Okay, we have seen the anterior oblique. The other one is dorsoradial, and it's nice to explore it when if you tend to sublux, yes, you tend to sublux the trapezium metacarpal joint. Okay, you abduct the thumb like this. You are able to put it in tension and to see if there is some fluid inside. And pay attention to not confound with this is also the insertion of the abductor. This insertion of the abductor pollicis longus. Okay, from the first compartment. They are very close, but with a little different inclination of the probe. Okay, this is the abductor here that you see here, and if you go a bit more volar, you have the dorsoradial. Okay, in this point, you see that they are very close to one each other. Okay, tendon. This is tendon, like this, and this is the ligament. Okay, and that's for the volar aspect of the wrist is the yeah, the last thing that could be interesting is the exploration of the exploration on the scaphoid. That is better if you do it in ulnar deviation. You see the tubercle, the scaphoid, and you see that this is the cartilage with until the joint. The cartilage here that articulate with the radius anteriorly, and just above it you have a very well almost homogeneous structure that is the complex of the volar ligament just above it. Is good to check the scaphoid like this just to see if there are any fracture, any irregularity of the bone, because you know that in for at least for radiology, this sometimes when the X-ray is not so clear in emergency department to call a fracture of the scaphoid. Sometimes if the symptoms of the patient are compatible with a fracture of the scaphoid, it could be useful to explore it also in on ultrasound. Okay, and of course check also for fluid around the scaphoid. That is a good point. It's something that we want to add for the volar aspect.
¿Algo más que queréis ver por la parte volar? The second row, perhaps, of the median between trapezius and...
Okay, okay, yeah, of course, you're right. So when I forgot to talk about so we see the first row here in between the pisiform and the tubercle, the scaphoid. The second row is just here between the tubercle, the trapezium, and the hook of the hamate. Okay, and you see very well the transverse carpal ligament, or that is the retinaculum of the flexor, and is nothing more than the continuity of the antebrachial fascia in the palmar aponeurosis, as Xavier let me notice in the previous day. That is an interesting concept of the continuity of the fascia. You see, but where you can when you can say that finish the flexor retinaculum and palmar fascia start, well, you can only use your landmark. You have the landmark that are the oculohamate and the trapezium tubercle. From this point distal, you have the fascia, and proximally you still have the transverse carpal ligament. Okay. And just pay attention at level of the hook or the amate is interesting because on the medial side you have the deep ulnar artery with the deep branch of the ulnar nerve. That is the motor branch, and this is just at the exit of the Guyon tunnel. Superficial to the occiput, we have the sensitive component of the ulnar nerve. This is the ulnar artery, the sensitive component of the ulnar nerve. This is the origin of the flexor digiti minimi, this one. And underneath you have the motor branch of the ulnar nerve. Remember that it's important to be aware of the anatomy of the motor branch of the ulnar nerve because sometimes, moreover in sportsmen, the sportsmen who go bicycling for a long time, you can have some neuropathy regarding the deep branch of the ulnar nerve because it's constantly compressed. So you can have a selective atrophy of the interosseous muscle, and it's important to check for the. Okay, here you see very well. This is the beginning of the Guyon tunnel. Okay, if you go distally, you see that there is the separation between the motor component, between the motor component just here and the superficial component here. Then you go distally. You go distally here in this point underneath the flexor digitorum brevis. Just underneath you have the motor branch here, here, going it passed very close. Sorry, it passed really on the here, very close to the interossei muscle and the flexor just above it. You can explore for a long track. It is important because sometimes when you have ganglion bulging from the metacarpophalangeal joint, you can have a compression of this branch. You can have a so selective atrophy of the interossei muscle. Okay. Usually when you have an ulnar neuropathy, you have a generalized atrophy of the interossei muscle because all the interossei muscle are innervated by the ulnar. But in very specific case, when you have the compression at the level of the motor branch, you can have selective neuropathy. You can have a selective neuropathy in this area, selective neuropathy of the interossei muscle. Okay, just something that could be useful to be aware because is a good diagnosis, and maybe you can solve the problem if you find that the ganglion go compressing the nerve in this point, for instance. Then you can aspirate, you can operate and solve completely the problem of the neuropathy. So I think that these are many things for the water. I don't know if there is time. Oh, sir. Yeah, and my thesis in radiology was about the motor branch of the median nerve. So it's is something that is interesting because so you see this is the median nerve. This is the antebrachial fascia just over it. You see the thin layer just here. Then it entered the carpal tunnel, and of course with that probe isn't, yeah, just okay. Okay, so for now I tell you that this is the motor range of the medial nerve. Okay, just here, here, and but the way to find that is just above the flexor digitorum brevis of the thumb, just over here. but the way to find it is it takes a bit longer to be explained. So it is a recurrent branch, okay? It is a recurrent branch that usually takes origin from the most lateral or the intermediate division of the median nerve just at the exit in the when the anatomy is normal. But the real technique to find that require visualization of all the thenar muscle, because I realized that the best way to find that, maybe even 24, thank you. The best way to find that is going systematically. Okay. Isn't not so good. Okay. The 18 maybe. Yeah, just a bit more resolution.
Yeah.
Okay, good, very good. You start at the level at the beginning, very beginning of the carpal tunnel. Okay, and look no more at the median nerve. You focus on the muscle. Okay, the first. This is the beginning on the of flexor retinaculum. The first muscle you see taking on the top of the retinaculum. This one is the abductor pollicis. Okay, this is the one, the most superficial here. If I progress distally, there is a second muscle there. That is the opponent's pollicis. Okay, and you recognize that because it's the only muscle of the thenar eminence that go to insert on the metacarpal bone. You see, is an opponent, so it doesn't go to the flexor, to the phalanx as all the other muscle, the thenar eminence, but it goes to the metacarpal bone. This is the metacarpal bone. So this is second row. The third row is when you see, this is when the muscle that's just overlie the flexor pollicis longus. This one, this is the flexor pollicis brevis. Okay, and this is in this point that you have to explore the presence of the motor branch, and so you can have it. So when once you are just over it, when just over the flexor pollicis brevis, and you have to check to the division branch of the median nerve in this point. You see these are the different digital nerve, and you have to see for the small branches going up and superiorly go backward. And these are the fascicle of the motor branch that go there, and this is where it starts from the division on the median nerve. Okay, just over the flexor digitorum brevis, flexor digitorum sorry, flexor pollicis brevis. Okay, so this is the division. This is the intermediate division of the median nerve. This is the radial division of the median nerve, and you see that from the radial there's this small branch that goes up, and then is recognizable on the surface of the flexor digitorum, flexor pollicis brevis. In this point, now that we have seen the muscle, we can go back to the superficial probe to confirm. Thank you. So again, we check, we do the same things. Flexor, abductor, the abductor, opponents. The last one is the flexor, and over the flexor we have the branch of the there. Sorry. This is these are the fascicle of the motor branch of the median nerve. Okay. Then if I go backward, you follow the branch, follow the branch, follow the branch. Here, this is the shadow you see here, the part where it go in depth and join. Go in this point to go in depth to join to take its origin from from the one division on the medial nerve. Okay, from here goes here, and then it goes superficial on this point over it. Okay, is another way to see sometime in long axis could be just to go over, check for the medial nerve in a long axis like this. Okay, this is the medial nerve in long axis. This is the short axis of the flexor retinaculum here. And you just look for at the exit, you see it very well. In this case, is a little variant to the anatomy because it goes inside. You see it very well, very nice. You see it takes in origin. Instead to go superficial to the muscle, it has an intramuscular course here, 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 here. Very nice. And then it goes superficial, okay? But anyway, your landmark is always the flexor the pollicis brevis and the median nerve at the exit of the carpal tunnel. You see very well in this case in short axis. From here, from here, from here, from here to here. Okay. This the teaching point of this part that was also the topic of my thesis is that the anatomy, the motor branch of the median nerve is quite variable. In most of cases, it's true that if you look on the surface of the flexor pollicis brevis, you always are able to find it. But the problem is the point where detached from the median nerve, because there are cases in which is within the retinaculum, the flexor retinaculum, exactly in the middle point that goes up then to the flexor pollicis brevis. Sometimes, as in this case, is within the muscle. The problem sometimes it takes origin from the ulnar part, ulnar part of the median nerve. And that's why it's very important ultrasound exploration before performing carpal tunnel release, because that is also called the $1,000,000 nerve, because if you cut it, you lose the movement of the thumb. Okay, so it's very important to pay attention to this nerve, and the best way is to find that on the flexor pollicis brevis and then trace it backward. You have to be sure of the exact anatomy. If you try to find it from the medial nerve distal, it's very difficult. You start with flexor pollicis brevis and go back. Okay? And we have time for the dorsal, or
We have 10 minutes.
just well, just refresh, quick refresh of the dorsal aspect. So for the dorsal aspect on the wrist, there are you have the 6 compartment tendons, but I think that is something that is well known. What could be interesting to focus on are maybe just quickly, you have the different compartment. Okay, so basically we have our 6 compartment of tendon, and this one is the first one. You see the variant anatomy of the first compartment here. Just be aware that there is also, in this case, there is the branch, superficial branch of the radial nerve just over it, and the first compartment could be also involved in the intersection syndrome. You see the passage of the first compartment over the second, and always regarding the first compartment on the floor, the first extensor compartment, you have the insertion of the tendon on the brachioradialis. Okay, here, and that go to insert the radial styloid just on the floor, the first compartment. The second compartment, it's okay, extensor, the extensor carpi radialis brevis longus. Okay, the brevis is here, go to insert on the third metacarpal, the longus go to insert the second metacarpal, and
Second, no?
yeah, in this case, you're right. Yes, this is a variation. Is a splitting. There is a split of the of the second compartment, the extensor carpi radialis longus, and this is the point of the second intersection between extensor pollicis longus and the second compartment. Okay, this is and if we move laterally, we have the Lister tubercle just there, the third compartment, and the fourth compartment. But if we look underneath the fourth compartment, there's a good point to check this ligamentous structure. This is the radiotracheal structure. Just okay. Here, from here is the fibrillar structure you see here is the radiotracheal. They go to insert on the tracheatum just there. And if you move the other, once you have on the tracheatum, you move the edge of the probe over more just perpendicular to the end. You see that there is a bridging structure that from the tracheatum here go to the scaphoid, and this is the intercarpal ligament, and the bone you see here is the distal part, of the capitate. Okay, this is the intercarpal ligament. You see it very well, and it's interesting because other than a good stabilizer, and the insertion point over the tracheatum bone is the could be the cause of avulsion fracture. You know. And this avulsion fracture in ultrasound could be quite clear, but if you have to diagnose it in with X-ray, you have to pay attention to look at the lateral projection, because it's the only point where you can see the detachment of this bone part. Okay, so something that could be very clear with the ultrasound and X-ray become a bit more tricky. Okay. And okay, then of course if we continue with the exploration, underneath the fourth compartment there is an artery with a small nerve close to it that is the terminal. This is the terminal branch of the interosseous nerve, the posterior interosseous nerve, and this is relevant because got to innervate the joint. Okay, so could be is responsible of the joint pain level of the wrist also. And so in case of hypertrophied synovium, somebody believe that the pain is also related to the compression of the small branch by the hypertrophic synovium on this level. Okay, but again, this is more these are more speculation than there are no really evidence that demonstrate that, but is a nice speculation, I guess. Moving ulnarly, there is the extensor digiti minimi just over it, and most lateral and most ulnarly, further ulnarly, you have the extensor carpi ulnaris. Okay, that is quite interesting because when you are in the shallow aspect of the ulnar styloid, you have the retinaculum. You have two structures to keep the tendon inside. You have the retinaculum and you have the subsheet of the tendon. Okay, so sometimes with even with the retinaculum intact, you can have some subluxation of the ulnar the flexor carpi ulnaris because of a lesion of the subsheet. Okay, and of course you can also perform the dynamic maneuver for to check if there is a snapping of the flexor carpi ulnaris, the extensor carpi ulnaris. Sorry, you place the probe here, and then you rotate the end like this. here. And you see if there is the snapping of the ulnar nerve just over the bone, okay? Snap ulnarly of the snapping ulnarly of the flexor carpi ulnaris respect of the ulnar styloid, okay? Here is volar and here is dorsal, and this is the extensor carpi ulnaris. If there is a snap when you perform this maneuver, it moves more volarly, okay, and could be cause of tendon pathology, tendon irritation. Okay, that's it.
Una duda. Sí.
Yeah, that occurs. Do you want to demonstrate that? Because it's very. Give you.
Solemos utilizar la misma vía que hacemos desde el punto de vista quirúrgico. Estamos en el hueso grande, nos situamos generalmente, la manera más sencilla de encontrarlo es a través de la continuidad del tubérculo de Lister. Si vamos del Lister hacia distal, automáticamente vamos a llegar a la articulación entre el escafoides y el semilunar. Vemos muy bien el ligamento a nivel dorsal y lo que hacemos aquí es únicamente flexoextensión forzada y desviaciones, especialmente cubital y radial, sobre todo porque esta inestabilidad que se entiende que es en un plano, generalmente es en dos planos, con lo cual lo que vamos a ver es el movimiento hacia volar del propio escafoides. Aquí tenemos el ligamento y lo que hacemos es desviaciones buscando y siguiendo el mismo eje del ligamento única y exclusivamente para no ver si se abre, sino si se desplaza. Podemos hacer también desplazamientos de la misma muñeca en el eje sagital, de tal manera que estemos moviendo la muñeca hacia un lado hacia otro, pero la manera más sencilla es únicamente haciendo desviación. Veríamos en primer lugar donde está la flecha un derrame, que es el paso y la comunicación entre la articulación mediocarpiana y la radiocarpiana, que es el primer índice desde el punto de vista de inestabilidad, y posteriormente el desplazamiento en el plano axial del escafoides con respecto al semilunar. Esos son los datos más importantes. Ahí tienes el ligamento perfectamente. Hay que tener en cuenta que el ligamento más potente es dorsal y luego tenemos que flexionar para ir viendo toda la superficie del ligamento a lo largo, es decir, vamos haciendo un movimiento desde dorsal, que es la parte más potente, hasta en flexión máxima, hasta la parte más articular. Es un ligamento muy reforzado a nivel dorsal y que luego lo une en todo el eje, con lo cual si no flexionamos no lo vamos a poder ver más que únicamente el componente dorsal. Esa es la maniobra. Si hay una inestabilidad, se ve claramente el resalte, mucho más que la apertura se ve más en situaciones ya más cronificadas. Es decir, en la inestabilidad aguda lo que vemos más es el movimiento en el eje axial. ¿De acuerdo? Muy bien, pues yo creo que con esto, darle un aplauso fortísimo a Federico.